he advocated for me. And then I'm not a technology person, but there was an opportunity. So San Diego State, the director of technology, knows somebody through Microsoft and Pearson. And they had created a virtual standardized patient with the Microsoft HoloLens. Yeah, I know. I was like, I barely handle my phone. So technology got these, and they said, we want you to pilot them in the School of Nursing. So then the School of Nursing director said, sure. So they created a patient like that. You just put on the goggles and you see it unfold, and it has anaphylactic shock. Get some antibiotics in the ER, and within 30 minutes it's like dying. None of the other nursing faculty thought it was fabulous. Like, they're all busy. And so in the PhD program happens to be a technology guy. And this is his project. He presented up there, and he's like, Helena, none of the nursing people are excited. Like, this is amazing. Like, this is the first time in the world that this has been done. Oh, okay. So why don't you join? So that guy who I said volunteered to be my chair, he's like, yeah, I'll take you. Let's do it. So we now have, it's been presented in Australia, in Colorado. We have a book chapter out in the UK for med school. So opportunities. And now it's been pretty wild. So, yeah, timing is important, and just grabbing that. So.
That's great.
You'll be fine.
What is one characteristic you believe every leader should possess?
One. I think you have to be trustworthy, right? Because I think I was like, you have to have heart. But if you have heart just for yourself, I think that's not enough. Like, you have to be trustworthy. So I think in order to be trustworthy, you have to realize, like, okay, I might have a title or, be in the lead position, but I'm nobody without my team. And so I think that's been the most important thing. I think the best leaders I've seen, I knew I could trust them. They have my back. I don't mind working for them because they're trusting. If you have somebody who's not trustworthy, you hear the bickering and all the stuff behind the scenes. Yeah. You start to see people jockeying for position. So, yeah, I think trustworthy.
Good choice. So what do you do to ensure your own leadership growth and development?
Well, I went back to school, and then I stay connected. So all these things I do, I embrace. So the buzzword would be I embrace lifelong learning.
That's great. What advice do you give nurses going into a leadership position for the first time?
Oh. Well, you need to find a mentor. Somebody you can trust who will give you advice. And especially for nurses, it might be good to have a non-nurse, right? Because nurses don't always have that kind of experience. And so now I sit at the table with the CEOs, strategic officers, the physicians. Often I'm the only nurse there, and that's been really helpful. It's like, okay, so Larry Lewis and I, or Dr. Edward, like, okay, what is this? This makes the 5th board that we've been on together. Or Dr. Baig at Clinica is like, now we're in leadership together, and it's been fun. So I ask them questions because it's a different perspective, and then they ask me questions, and they're like, we need a nurse. And so it's been fun now because now everybody says, okay, any type of thing we're going to have, we have to have a nurse. And so now it's like, I don't have the time, but now I have nurses like you guys, like, oh, hey, they're in a mentor program. Yeah. So that's the main thing, is get a mentor.
That's good. Let's see. So as you look back, would you identify 1 or 2 things that are your most important contribution as a nurse leader?
Well, you know what? I guess I would have to say it's this developing educational pathways, right? Because that's been critical. And then I think the other thing is our nursing council.
Yeah,
I would agree, because that's the only time we can get together and celebrate. So yeah, those are my 2.
Okay, and more nurses are needed to provide leadership in today's healthcare system. What do we need to do as a profession to improve the leadership role for nurses?
We need to grow our own. So especially in the Imperial Valley, it frustrates me. I think it's good to take field trips and to be able to go away and see what works there, what doesn't work there, and what might work here. But if we don't have our own leaders that understand the community and are trusted by the residents, it's hard, right? So we see time and time again, I think it's good to have a mix of leaders from the outside and the inside, but in terms of nurses, I think we need to grow our nurse leaders here, right? Because you know exactly what it's like to live here, to work here, and you get frustrated, right? When you have all these people coming in and think they know better, and then they leave. They make a mess before they leave, and then we're still stuck with it, right? And I think the other thing in terms of us is to not, so you remember all the roles I talked about? So it's caregiver, it's case manager, there are other roles. It's leader and politician or advocate. And so I think that's the other thing, is not mind being called a leader or like a politician. We think of it like as bad words in nursing. I'm like, no, it's important.
It's part of it.
So
Yeah.
I think that's the biggest thing. And most of our local nurses, it takes a long time. So look at like Erica and Steven. So back in 2009, they graduated, and they really had that imposter syndrome bad. And so now Erica says, I need new friends, Helena. You just like, I have a new language, and now, so, you know, we're sitting there starting the critical care chapter. I would have loved to have started that when I came back in 1997. I wrote the protocols for like ventilators and stuff because I'm like, we have no standing orders. Like, this is nuts. And so now I'm like, wow, this is really cool. But for them to be a leader, it's taken, we're at like 10 years because they didn't see themselves as a leader.
Right.
And it took a lot of mentoring and for people to invest in them. And now it's so funny. They're like, you know what? She sent me her slides for the EKG class she just taught for critical care. I'm like, dang, girl. And she goes, you know, I felt like we had to use Dr. Carlson's, or we had to do this. Like, I'm not good enough. I'm like, who else knows what's happening?
No, she's really
So you
good.
see that, and now, like, I think of you guys, you're, you know, the route you're going is known, FNP, but like the midwives, they are leaders. They had to be pioneers. So it was okay for them to do their clinicals, but when the physicians realized how much money they were going to lose, they wouldn't give them privileges. It's taken
That's
them
true.
like 3 years to have privileges. So, you know, the CRNAs, like, you know, they broke through at PMH. So now my next thing is we need NPs as hospitalists.
Yeah.
We need to be a blended team. The physicians and the hospitals always think, oh, bring in more docs and we'll have better quality. The hospitals, when I first started, we didn't have hospitalists. We were there by ourselves. And so that didn't quite solve the quality problem. So for me, it's like, well, you have to have nurses, but they have to be leaders. They have to understand that world. It's a business and it's very political. So yeah, okay, enough of that one, sorry.
So Christian's gonna ask you now
Okay.
a few more
More,
questions.
we're gonna focus more on the health care costs.
Yes.
I think currently there's an outrageous skyrocket in the prices of healthcare. What do you think is one of the main barriers when dealing with like money?
So unfortunately, right now, the hospitals and especially the hospitals and physicians, the only way you can keep doors open is to treat a disease. You have to do multiple procedures and things. So the sad part is there's not a focus on prevention, primary care, and keeping people out of the hospitals and doing all the expensive stuff. So we're based on a model of disease, not a model of wellness. And so that's the challenge, isn't it? We don't have enough primary care providers. And the ones we do have won't see Medi-Cal. So there's no prevention. And so our system is broken and it's spending money in that end of life. Another thing you think about is, especially in our community or our culture, we don't talk about end of life. So I believe the most dollars spent in our community, and I think it's across the United States, is in the last 6 months of life. So think about how many 98-year-olds end up on the ventilator because no one had an advance directive, didn't have the conversation at that primary care level about what they wanted. They don't want to die in the hospital, but now you're in this position where the family then doesn't want to say, don't do everything. So it's a broken system. So sadly, we don't do anything on the preventative side, but it goes back to policy and reimbursement. And the other thing is when we talk about like pharmacy, and so they totally are driving that market. So you have a lot of primary care practitioners that can't stay afloat. They're having to now open urgent care centers and things so they can keep their bottom line healthy. And so you want to be a surgeon or a specialist because that's where, so it's a broken system and it's multiple levels, but I think it's the model of healthcare right now, and we're trying to move to that model of wellness, but the challenge for that is we can throw a lot of money at trying to tell people to eat better and to exercise. quit smoking, but they don't necessarily choose that. So there's that divide as well. Do we then pay for their health care if they chose to do those things? So there's a lot about health care. So I would say it has to do with, the finance and what we are financing right now, and then what do we do to invest in that prevention? It's a challenge, because think about now our kids, we have so many who are overweight or obese, and so by the age of 18, they already have type 2 diabetes, we have tons of polycystic ovary disease, they're having heart attacks in their 20s, so it's the first generation that's not going to outlive their parents. It's kind of sad, huh? And then you see in our hospitals, we don't have enough staff, so we have to pay registry. What does that cost? So you kind of think at the model in nursing, you don't get paid extra if you give really good education, right?
Yeah.
It's get them in, get them out, don't let them come back in 30 days. So it's a broken system, and I think first of all it's the model, the policy of what we invest in. We don't provide an opportunity to do all levels of healthcare, and I don't know what'll be the tipping point. It's pretty sad. People can't afford it. So healthcare reform, we gave everybody insurance cards, but we still didn't have providers. So it's kind of like, so then they all come to the ER, right?
Yeah.
And when talking about patient to provider ratio, I know there's like a 24 after discharge or the first follow-up appointment. It takes like 24 days for them to follow up again. Do you think advanced practice nurses will help ease that and also the cost on healthcare?
Absolutely. But in the state of California, the challenge is you guys don't have, the scope of practice is inhibited, and you're not reimbursed at the same level. So you're having to now practice in a medical model. Whereas an NP, you're that holistic, practitioner, and so they're making you then, you have to align with the physician model, and it's just getting them in and out. So I agree, in our community, we need mid-level practitioners of all types, because I think that's how we fill in those gaps. And actually, I can explain that my son has type 1 diabetes since age 7. At Children's, we had an option to have a nurse practitioner who was amazing. We'd had the physician, we had her, and there was a difference in the way that she approached us, right? She could speak the same language, and she did a much better job at teaching and following through. Where the physician, it's here's your diagnosis, here's your prescriptions, I'll send the nurse in. But you need to have that relationship with your provider, and so that's where I see NPs. That's why I wanted to be an acute care NP, because it was like, wow, it brings a different dynamic to the table. So what I like to explain is the medical model is based on a curative model. Here's your diagnosis, and here's your prescription. It's either medicine, we're gonna have surgery, or here, let's radiate you, chemotherapy type thing. And when it's about quality of life, palliative care, then like, okay, I'm done with you, like, not sure where you go, right? It's focused on saving you no matter what. The nursing model is curative, and that means we care for you across the lifespan, and we understand the physical, psychosocial, and spiritual realm. So I think that's the difference in that model, is we can do the same thing with a diagnosis. As NPs, you're gonna do that, but it's more about the patient and the coping, right? It's more about what we call the social determinants of health. Have you guys read about that yet? So that'll be in finance and community. So if in the puzzle, when we talk about health, there's different components of this puzzle. Having the best hospital and doctors does not make people healthy. It's only about 8% of that whole big puzzle. It's more their education level, their economics, their social networks, do they have transportation? It's those things that usually determine health. And you think back to like Maslow's hierarchy of needs, like most of our community is low income in survival mode. Like they're just trying to figure out housing and food on the table. They're not thinking about like tomorrow or next year. So there's not planning that goes into that. So that's where I think an NP serves us well, because you can do all those things. So yeah, absolutely. And in Imperial Valley, we have to have that. That's why I say we have to have advanced practice nurses that see themselves as leaders, because you'll have the voice for the community. Yeah.